Hello, everyone, and welcome to our session today, to our webinar series. Today, we welcome Dr. Campbell, who was here a few weeks ago talking about dialysis options and deceased organ donation. Today, he will talk about live organ donation, but he brings a twist to the webinar, showing a video of a live donation to show you how it is done, to demystify the process for those of you who wonder how it is done. Well, I know I do because I'm a recipient. I would like to watch too, but I'm squeamish. I really am. But I might just watch because I really do want to know how the process is done. On that note, I would like to warn people who don't have a stomach for blood or to watch this type of videos. Please take a break for 10 minutes and come back when the video is over. I'll be peeping through my fingers. So without further ado, let me introduce Dr. Campbell. Good afternoon, Dr. Campbell, and
Good
thank
afternoon.
you for giving us your time again today. Dr. Campbell, everyone.
Okay. Good afternoon, everybody. I'm going to be talking about living kidney donation. As we know, there are two sources of organs we use for transplant: disease donor organs and live donor organs. So we're going to be looking at live donor organs, looking at the benefits of live organ donation. And we are going to also try to address the donor organ shortage. What are the issues? We're going to be looking at the BAME communities and live donor organ donation. And we're going to talk about how we evaluate potential live donors. I will talk about surgery as a surgeon, and like you heard, I'm going to show you a short video if you are able to watch it. Then we'll talk about the follow-up arrangements after donor surgery, and then I will take some questions after that. But before the live donor surgery, we're going to have a short break. Thank you. Now, we know that live donor transplant is the best option for patients with end-stage kidney failure. And there have been a lot of issues regarding the shortage of organs for transplantation. So there has been national efforts ongoing to address the shortage. And that is by including increasing the live donor transplant rate in the UK. Currently, it's about 28% of transplant performed are from live donors. In Netherlands, the figure is much higher. It's almost about 50%. Now, so the UK is trying to do better. So we are doing a lot of investment has been put into it, and a lot of effort actually has been put into trying to increase the live donor organ rate. Now, why do we talk about live donor? Live donor tends to give you options that a disease donor transplant will be difficult to achieve because it can be organized in a predictable manner. So if somebody needs a kidney urgently, live donor is the only way to get one. Disease donor is very unpredictable. So that's one. And if you want to have a kidney before you start dialysis, live donor is the option that most people would like to take. Now, before we do live donor transplant, of course, we have to evaluate the donor very carefully. And that is to make sure that the donor is suitable to donate. And also, we want to make sure that we can minimize the risk to donation for the donor. So there are some donors, if we feel the risk is too high, we may say to them, sorry, we will not, we don't think it's a good idea. We will not want to carry on. Now, the process of evaluating donors is quite resource intensive. It's very comprehensive and time consuming to make sure that the donor is not harmed in any way. And And also, we want to make sure the donor gets a very good experience of the health service during workup. And also, we want to ensure that the donor is able to continue living healthy life after donating their kidney. In fact, we follow donors up to make sure they are able to achieve this. Now, what has the government done over the years? Apart from the technological and development and clinical expertise, they've changed the legislation actually to improve the opportunity and choice in options for living kidney donation and transplantation in the UK. As we know, it's cost-effective alternative to dialysis. It's cheaper than dialysis. And if possible, it allows about 50 to 60% of eligible recipients to consistently be preemptively transplanted, avoiding dialysis. We are only able to achieve this with deceased donor in only 7 to 15%, but we can achieve only almost 50 to 60% if we use live kidney donor. Now, why do we talk about preemptive transplantation? Is because it's associated with improved patient and graft survival. And it's unfortunately is less common among racial minorities and also less common amongst those who have less education and those who must rely on Medicare or primary payments before they can have their transplant. That's what some research studies have shown. Now, how do we expand the living donor pool? What I've done here, I've looked at it as what are the roles of each member, each person, each organization, each community, hospital, and also the government. What are their roles in expanding the living donor pool? Individual, interpersonal relationship, community engagement, institutional, that means the NHS, the hospitals, the transplant centers, and then the policymakers, the government, and the funding bodies that provide fund for the healthcare. Now, for the individual, it's important that you make the decision to donate your kidney known to your family and close friends. And because they are going to be there for you, they're going to support you, they're going to look after you after when you are recovering. And if things don't go well, they're going to be there for you to support you. So it's very, very important. Now, also, it's also important to uphold patient autonomy. That is, the patient is the only one who is making the decision to donate their organs, not because of pressure from family members or from friends or close friends. The individual can also use social media to share experience to promote live donation. And we have also found from research that each individual has to motivate themselves and educate themselves to improve, in order to improve their health literacy, because there are a lot of issues, a lot of things that you need to know about kidney transplant and donation. Now, how about interpersonal relationship? You can promote positive mindsets of family members and close friends about donation. You can engage in open discussion about kidney donation in the family or with your friends. You can demystify live donation and transplantation while discussing with people. Spread your knowledge. You can also support family members in improving education and health literacy. You can help family members and to promote, and also friends to promote healthy lifestyle. This is aimed at reducing obesity and kidney disease. You can also engage actively with healthcare staff in helping to support live donation. Now, how about the community? What can the community do? The community is very important that we be able to understand the key barriers to donation in your communities, to establish trust, connection, and relationship with the community, and to formulate effective communication strategies with key members of the community, and then to engage the community and their leaders in organ donation awareness raising campaigns. This is very, very important. And to seek support, NHSBT, other charities, to sustain the implementation of solutions to improve organ donation in our community. Now, to continue to monitor success or failures so as to identify what works, what has not worked, and to change it, and to concentrate and focus on what works. And also to explore and implement new strategies to achieve set objectives. When we know what works, we would see how we can make it work better so we can improve the number of live donation in our community. These are all that the communities can do. How about the institution like the Transplant Center, the other organization? Now, what we do in our unit is to try to improve the timeliness of live donor transplant by embedding the practice of transplant first in all discussion with patients and their families. What does this mean? When a person becomes a patient with kidney failure, the first thing to talk to them about is about transplantation. Dialysis can come. Discussion about dialysis and plan about dialysis can come after you've told them about transplantation, because to get a live donor, it takes a lot of time, and you need to set the ball rolling early to be able to be successful, to find a live donor. So it's very, very important we talk to people as soon as we know they have a diagnosis of kidney failure, they are not on dialysis, their kidney function is fine, they are fine, they are working, they are doing everything. We start telling them, we need to transplant you when the time is ready. Now start thinking about how this is going to happen so that you can have your transplant before you have dialysis, because we know it's the best form of treatment you can have. Now, what other centers have tried to do, especially with the minority communities, is to do this discussion, to have this discussion during home visits about live donation, to make sure that potential recipient family members are present, so they can hear everything with their own ears, in their own home, in the safety of their home. They found that this approach actually has helped a lot to increase the number of people coming up as donors for their family members. People find hospital visit quite daunting and stressful. But if you go to their homes to discuss about live donation, they tend to be more receptive. Now, also to improve the clinical pathway for potential organ donor workup, to remove bottlenecks, improve patient experience and clinical outcomes for both donor and recipient. This is very important. We try our best. Live donors are like VIP in the health service. When they come in, we treat them, very, very well to make sure that they have very good experience, and so that they can also help us to pass on good messages about live donation to other people. So we take them very, very seriously. Now, there is also the need for continuous staff education about live donation. So we continuously, because staff are coming and leaving, so we have to continue, we can't stop. We also have to prioritize resources to deliver effective patient-centered care for donors and their families. As we know, resources are, is an issue in the NHS. So I can assure you that in my hospital, they do their best. When everything else is down, they will say, no, we must do live donors. Even while COVID is going on now, the hospital is canceled everything, all our elective operations, but they let us do live donor surgery just to see how important they take live donor transplant. How about the government? The national policy, what have they done to improve live donor transplant? I can say, because I've worked many years in this job, they've done a lot. The national health policy is to support live donation, and also to support public awareness campaigns and confidence in live donation. In fact, there is money available with NHSBT for communities who want to promote live donation in their communities. If you contact NHSBT, they've put some monies aside to help, to promote live donation. Now, community health promotion to reduce prevalence of kidney disease is also quite important. At the same time as we are treating the disease, we are trying to reduce the number of people that come down with kidney disease. Now, the government has also set up the shared living donor pool, which is being used now effectively through the National Living Donor Kidney Sharing Scheme to make sure that those who cannot donate but directly can donate indirectly. I will say a little bit more later about this. Now, also to remove disincentives to live donation for all population groups. There's still a lot of work to be done with this, but there is some work to be done, because if some people are still experiencing problems, difficulties donating their organ, even though they do want to donate their organs. Now, when we talk about donation, direct donation, transplant, we go ahead if the donor and recipient are compatible, blood group compatible, HLA tissue type compatible, and cross-match compatible. That is the only time. In fact, many years ago, before 2004, is only this type of transplant that were allowed in the UK, but not anymore. Now, in order to overcome the immunological barrier to live donor transplant, it's now possible to have indirect donation. That is, somebody can donate to somebody else, and then somebody donate to the other person, and the two incompatible transplants will be possible to be done. Now, we call this kidney sharing scheme. This has helped a lot and has contributed a lot to increasing the number of live donor transplant that is now possible. Now, this is the UK Living Kidney Sharing Scheme. And what happens, there are two types. We have the paired donation, and then we have the pool donation. In the paired donation, donor one we donate to recipient 2, and donor 2 we donate to recipient 1. This is done the same day. The two donors are put to sleep at the same time. It's very highly coordinated. The kidney travels. The donor or the recipients do not travel. And we've not had any problem or any donor changing their mind since this program started. So it's been working very well. Now we have the pool donation, where you have more than 2. So donor 1, we donate, for example, we donate to recipient 2. Donor 2, we donate to recipient 3, and then donor 3, we donate to recipient 1. At the moment, this is what we call a 3-way exchange. In the US, they've done a lot more exchanges. In fact, they were able to do almost 60 transplants, just kidney exchange from one donor to the recipient across the country. So this enables more transplant to happen, which before it will not have happened. Now, coming down to the back to the BAME communities, of course, there is no doubt that there is need for more people from BAME communities to donate their organs. either in life or after death. But we're going to focus mostly about donating their organs in life today. Now, why is this? The reason are ethnic variation. There is ethnic variation in blood group and HLA tissue type. So BME spend longer time, because we know they spend longer time on the transplant waiting list than the other groups, especially. So there is a need to reduce this discrepancy, to make sure that they are able to also get a transplant quicker. And although there's been a lot of effort to reduce the waiting time for transplant, and that's actually worked very well. And unfortunately, yes, the waiting time for all groups have gone down over the years. At least in the last 10 years, it's gone down, but it's not gone down equally. So the BME community still are still waiting longer or longest, compared to the rest of the other groups. Now, the other thing that was noticed was that, talking about the opting in law, opt-out law, it looks like a greater percentage of BME members are opting out as donors for even deceased donors. Now, there are logistical and legal complexity for recipients in the UK with potential donors who live overseas. It's another problem which is being addressed and can be quite problematic. Now, there are also difficulty finding suitable donors because of the higher risk of kidney disease. You see, when you have a family, when there are loads of people who are diabetic, and then they may not be suitable as donors, or who have hypertension and have other medical problems. They may not be as suitable as donors. We do take kidneys from diabetics, but it's got to be very, very good functioning kidney, and the diabetes should not be very bad. Now, a study also showed that socioeconomically deprived individuals in the UK are less likely to receive a live donor kidney transplant. That's surprising, even though transplant is free, donation is free, but they found that those who are socioeconomically deprived are also less likely to receive a live donor kidney transplant. There's a lot in that. I don't think we have the time now to talk about that in very great detail. Now, in BME communities, it's been found that there are concerns that individuals are making decisions not to donate based on misinformation, misplaced fear, or misconceptions about faith beliefs. This is a long discussion. If we want to go into that, I will just leave that for now. Now, the attitudes towards organ donation among BME communities vary depending on ethnicity, cultural values, and religion. And education is what we need to use to be able to address these issues. Now, the BME leaders and organization are going to be working with the NHSBT to improve community education about organ donation, promote faith and cultural engagement, support awareness-raising campaigns, family members made aware of their wishes regarding organ donation, and to support them to donate their organs, and also to help to demystify the prevalent myth around organ donation. It's a lot of work. I want to say here that what people have been doing before now is obvious that it's actually now yielding some good result, because we are seeing increasing number of BME communities coming forward as donors, including live donors and also deceased donors over the last 5 to 10 years. So there's still a lot of work that needs to be done. Now, the number of BME living donors has remained at approximately about 140 to 150 per year, representing 14% of all living organ donors. Last year, there were fewer white living donors, whereas Black and Asian living donors remain stable. That's the from the NHSBT or report, which showed that things are getting better, but they need to there's still a lot of ground to cover. Now, the Human Tissue Act of 2004 opened the door for everybody to be able to donate, including allowing even altruistic donors. That is, people can come forward and say, I want to give my kidney to anybody. And I don't care where the kidney goes to, and we are able to do that. Many, many years ago, before 2004, we were not allowed to do that. Now, to be able to donate, you have to be greater than 18 years old. There's no upper age limit. In fact, an 85-year-old woman has donated her kidney and she was fine. But it's important to know that it's illegal for any donor to receive financial compensation from the recipient or their family. The donor can be compensated for loss of earnings and personal costs by NHS England. The transplant team may decline to accept a donor for clinical reasons. Now, if you are thinking about donating, what should you know? Now, like I said earlier, please discuss with your family and close friends. Now, please note that donor workup can reveal new health information, including genetic relationship with the recipient, which may surprise you. Now, also, donor health information may be divulged to the recipient if it will affect their future health. If it's not going to affect the future health, we will not tell the recipient when we find anything about your health. Now, relationship with the recipient often improve after donation, but may get worse, especially if the recipient outcome is disappointing. These are things that we tell the donor who comes, just to be aware of before they proceed.
And if you're watching right now, I would ask you to start writing your questions in the comment box, because that is going to go up on screen. I have quite a few questions coming in by WhatsApp. If you cannot type into the box, or you find it difficult to actually type into the box, then just send me your questions by WhatsApp. You can actually type your questions into the Facebook comment box, and also you can do that if you're watching from the YouTube channel. If you're watching right now and you're enjoying this and you're getting a lot of information from this webinar today, I want you to just keep liking and loving this webinar. If you're on Facebook, if you're on Twitter, if you're on YouTube, do the same. So I'll bring Dr. Campbell right back now for the next version. So let's welcome Dr. Campbell back to the webinar.
Donor assessment. How do we assess donors when they come in? The primary goal is to ensure the suitability of the donor. Is this donor suitable to be a donor? And also, we want to make sure that we minimize the risk of donation to the donor, because like we know, we don't want to do any harm. So we assess them very, very carefully, that to make sure that at the end of the day, we will have done no harm to the donor. Now, to ensure the suitability of the donor, we looked at the general health. We take a good history about their health. We do tests to establish whether the donor has any transmissible conditions such as infection or cancer. Unfortunately, sometimes we do find some donors actually have cancer that they don't know about during the evaluation. And we just say, sorry, you can't donate. We have to treat your cancer. We send them for treatment. because this early stage cancer, and most of them that I'm aware of have done very well, so they could not donate. So coming forward to donate made it possible for us to diagnose early cancer for some of these patients, for this patient. Now, acceptable kidney function. We want to make sure that the patient, after donating their kidney, they will still have good enough kidney function to have a normal life, to lead a normal life. We also want to check whether the patient is compatible, blood group and tissue compatibility with the donor. This is only in case of direct donation. And we also want to do psychological state assessment to make sure that the person who is giving their organs is okay psychologically. So we don't want to exploit anyone. And sometimes, if we need to, we will send some patients for psychological assessment to see a psychologist, very, very rarely to see a psychiatrist if we are concerned. Now, to minimize the risk of donation, and also, so we have to make sure that we know what the health issues are. We want to quantify the health issues. The fact that you have a health issue does not mean you cannot donate. We have to make sure that the health issue is not serious. And also we want to make sure we quantify the anesthetic risk to having an operation. We also look at the perioperative surgical risk to the donor and make sure that it's acceptable. Again, renal function. The renal function must be adequate once a kidney has been taken away from the person to make sure that he can continue pre-donation activities. The workup, this is how it works. When the donor contacts the live donor coordinator in the transplant center, the live donor coordinator will send them what we call donor health screening questionnaire to fill, just a screen. And some donors are told, sorry, you can't donate from what they've written in the questionnaire, but majority will be accepted. Now, so they would go to the next stage. The live donor coordinator contacts the donor for a brief interview. They bring them into the hospital and they have a brief interview. They go through what they have written down or what they've completed in the initial screening questionnaire. And if there are issues, they try to find out more information about what they've written there. And then they organize initial screening tests, which will include blood group, renal function, and so on and so forth. Just initial tests, just blood tests, just to see whether we find something. Very, very rarely we do find at this stage that somebody cannot donate. And we just say, sorry, your renal function is not as good as what it should be. Sorry, we can't take your kidney. And then for those who the results are okay, we move to the next step. The next step will be the nephrology clinic appointment. The nephrologist will look at all the results put together and will sit down with the donor and will explain the outcome, the reports. And then the nephrologist will tell the donor what they think about their suitability of being a donor. And the nephrologist will write a letter to the surgeon and ask the surgeon to evaluate the donor. The surgeon will bring the donor into hospital. Now we don't bring them into hospital anymore. We can do it from home, online. The surgeon wants to look through all the results and make sure that he is happy, and raise some concerns if there are a need to raise concern about certain issues. Sometimes you find you have to tell the donor that if you are donating, you are committing yourself to changing your lifestyle. If you don't want to change your lifestyle, maybe you don't want to donate, because some people need to take certain things more seriously. Like if you are obese, If you're a smoker, for example, and if you have high cholesterol, you have other issues, that should not stop you from donating, but it will you need to change to because when you are living with one kidney, you need to be good. Now, it will also talk about the risk of donation, the risk of the operation, and then the risk of the anesthesia, and what may happen after donating the kidney. It will talk about, of course, the benefit of donation. And also, and at that point, the surgeon will usually fix a date and agree a date for the operation with the recipient. Now, the recipient also attends at this time, but the recipient is not interviewed at the same time as the donor, just to make sure that nobody is influenced by anybody. Now, once the date is fixed for surgery, the donor and recipient will be brought in usually a day before the operation, and they will have another test, some tests done, simple tests done. The anesthetist will see them, and then they will take them to theater. Now, like I was saying earlier, the routine screening investigations for potential donor is a lot of tests, and that's why it takes some time to be able to organize. It's a lot of tests. This is a list of investigations that we do for patients, for donors. Now, before we go on, let's just say who can donate, who cannot donate. If you are less than 18 years old, you probably will not be allowed to donate your kidney in England. And if you have transmissible conditions like HIV, hepatitis B, hepatitis C, or you have melanoma, lymphoma, or other cancers, you cannot donate your kidney. If we find that you're unable to consent for surgery because you are because of some other difficulties, or you have ongoing psychological or psychiatric condition, learning difficulty, and all that, we will not take your organs. Ongoing serious medical conditions. If you have a severe heart disease, very bad, severe diabetes, your hypertension on more than 3 agents, meaning it's difficult to control, we would not want to take your kidney. If you got metabolic urinary stone disease, we may not want to take your kidney because you may get stone again, which may damage your kidney in the future. If you've had a previous treatment for cancer, we may or may not take your kidney, depending on the type of cancer. If you have only one kidney, of course, we will not take your only kidney, because some people will discover they have only one kidney during the workup to be a donor. If you have abnormal kidney anatomy with multiple renal arteries, we may not want to take your kidney. And also, if you have kidney function, of course, below recommended guideline, we will not take your kidney. Now, what are the surgical techniques that are being used currently to remove donor kidneys? These days, almost 100% are done laparoscopically, keyhole. Almost all centers in the UK offer the keyhole surgery option. And there are 2 types of keyhole surgery option. There's the one we call hand-assisted option, and then the other one is total laparoscopic donor nephrectomy. Total laparoscopic, there are so many different variations to the same operation. But the one I do is the retroperitoneal total laparoscopic nephrectomy. Although it is also possible to remove donor kidneys by open surgery, but these days is uncommon to do. We do it sometimes if it is impossible to remove the kidney by laparoscopic means. Now, if you don't want to watch this video, please, you can take time off now. It's only for just 10 minutes. You can come back after 10 minutes. This is the video from given by my colleague, Sanjay Mehra, one of the consultant surgeons in Royal Liverpool Hospital. Lend me this video. This is what I do. So the first point is to mark the area. The patient is placed on the side, and then we make small incision. That's what we call the keyhole incisions on the side. Keyhole is only just about 2 centimeters in length, and we take the incision down into this kidney space, and then we pass an instrument, we call it a balloon, to create space in the retroperitoneum just around the kidney. That's the camera going into the space, and that's the space. We blow the balloon to create the space, and then we put a port. That's the first port. That's the port. Port means what we are going to use to get access to the space. So we're going to put a camera inside that port, and then we create another port. That's an instrument port. It's a 5 millimeter instrument port. And then we make another port at the side. This is another instrument port, but it's a lot bigger. It's 12 millimeter instrument port. It's just because of the size of instruments that we're going to pass through the ports. Now, the first thing, now you can see as you go in to the retroperitoneal space, you look for the ureter first. So we have a very nice equipment to minimize the bleeding during the operation. As you can see, there is very, very little bleeding during the operation. The blood loss is very, very little. There is no need for blood transfusion in this operation. I've never transfused a patient since I've been doing this. So, because the blood loss is minimal. And so as you can see, you can't see bowel, you can't see anything. The only thing you see is just fat, muscle, kidney, and the vessels. So we create the space and we look for the ureter. That structure you are looking at, which is whitish, this is the ureter. The ureter, that's the ureter. So you want to separate the ureter from the rest of the structures around it. So we separate the ureter, we separate the kidney, we separate the artery of the kidney, and whatever is attached to the kidney will be separated from the rest of the structures around it. So that's the procedure. Now we want to dissect the blood vessels that bring blood to the kidney and take blood away from the kidney. We try to find where the blood vessel is. As you can see, there's a blue structure there, which looks like a vein. So the surgeon is going to try to find the vein, find where it's attached to, where it's going, so that he can target it and divide it with a special instrument. We call it ligature. The instrument will stop the bleeding and will also seal the vessel at the same time. It's an amazing instrument. And that's the instrument is now trying to separate the tissues around the artery. That's the artery you're looking at. Yeah, that the blue one is the vein. So it's going to cut that small vein, which is the lumbar vein, so that the kidney can come out later. If you don't divide these veins, you cannot remove the kidney. To be impossible to remove the kidney. Now, so that's the artery being dissected, and then you're going to see the kidney vein or the renal vein in a minute. Now, so the section of the structures are around the artery of the kidney. Now we're going to go towards the vein. That bluish structure there that you're looking at, that bluish structure here, this is the renal vein. That's the renal vein. And that renal vein, and this is the gonoidal vein. There's another vein that comes from the gonads, the ovary for women, the testes for men, and drains into the renal vein. And this is the junction there. So he's going to have to divide that later. Now he has to now separate the kidney from everything around it that is attached to. So that fat, we call it Gerota's fat, is going to remove the fat away from the kidney, so the kidney can come away, and it's going to separate it from everything around it. So we are, as you can see, you will not see bowel, you will not see anything. It's just at the back. Everything is done at the back. That's a big advantage of this operation, because you're unlikely to damage any structure inside your tummy. The liver, the spleen damaging, no, it's not likely to happen here. The bowel is not likely to happen because you cannot even see bowel. So the kidney is now mobilized, is now separated from everything that is attached to it, so that to make it free, it's got to be done step by step, step by step. Now, the upper pole, the upper part of the kidney is now being separated. So everything is being divided under coagulation. It's a machine that sends electrical impulses to the jaw of the forceps that coagulates the tissue and stop the bleeding. And it's an amazing machine. That's it. It just stops the bleeding and also cuts the tissue at the same time. So the surgeon will go ahead and separate everything. The adrenal gland is located right at the top of the kidney, somewhere here. So it's going to stay away from the adrenal gland. Very soon, we are going to see the adrenal vein. That's the adrenal vein that is now going to try to divide it, because the kidney is also attached to the adrenal vein. That's the adrenal vein. It's going to have to divide it. So to detach it from the kidney, that's the adrenal vein that is trying to prepare for division. Again, the machine goes in and divide the vein and cut it at the same time, stop it bleeding. And then it go back now to the renal vein, to the kidney vein video. So, and that's, we just divide all the structures to separate the kidney from its attachments, separate everything, and then we're going to see the adrenal vein again. So the adrenal vein is going to be divided to separate it from the adrenal gland from the kidney. And that's the adrenal gland is being divided. Adrenal vein is being divided. And then now we have the kidney, then the gonoidal vein also will be divided now. That's the gonoidal vein, which is attached to the renal vein. It's got to be divided to be able to remove the kidney. There's not going to be any problem with the gonads. The gonads will not stop working because you have divided the gonoidal vein, because there are alternative pathway for blood to flow. So no damage is being done by doing this. Nature is very clever. So we will now, that's the ureter. It's going to now cut the ureter. To cut it, you have to put some clips at the lower part so that urine doesn't come back, and then we'll cut the ureter. So that's an irreversible stage of the operation. Now we have to remove the kidney, isn't it? Before we cut the artery and the vein, we make a hole in the groin area. The hole is just about 6 to 7 centimeters in length in the groin area on the side where the kidney is coming out from. We open the vein, we open the space. The hole is just big enough to allow a kidney to come out through it. So we go back now and we go and staple the blood vessels of the kidney. Again, we have a stapler, which is a beautiful equipment. It just staples, stop the artery bleeding, and also cut it at the same time. You don't see a single blood coming out. It's an amazing instrument. And then you go again, and then you staple the vein. That's the vein being stapled now. It's going to be stapled, and it's going to be cut at the same time. so that the kidney is now separate, so it's not attached to the blood vessel anymore. A hand goes in through the hole in the groin, and the hand of the surgeon retrieves the kidney and takes the kidney out of the hole. You will see the kidney coming out. That's the kidney. It's coming out, and the kidney can be cleaned up and then can be transplanted. That's the scar in the donor. So that's the end of my of the operation. So what happens after the operation? Now, most donors will stay in hospital just for about 2 to 3 days or 2 to 5 days. Most people will leave hospital within 3 days after their operation. They'll be able to look after themselves, not fully. We tell them you can't go to Tesco or Sainsbury at least for a few weeks. Let other people look after you, and you rest and you allow your body to recover. Usually after about 6 weeks, a lot of people can return to the activities they were doing before. Usually if you are somebody who is not engaged in physical, very heavy physical work, you'll be able to go back in about 6 to 8 weeks. But if you are engaged in very physical work, then you have to wait for about 8 to 12 weeks before you can go back. You have to ask your body to tell you when you are ready to go back. You are not, if you go back early, there's no damage whatsoever. You will not do any damage to yourself because you've gone back early. Your body will tell you that you have gone back early because it's going to shut you down. You'll be weak, tired, and you won't be able to move. You won't be able to do anything if you are overdoing things. If you've not waited for the body to recover before you start moving or doing things. You just do things gradually, steadily, a little bit at a time, a little bit more at a time each time, until you are able to return to your pre-donation activity. Everybody is different. Some people are quicker than others. It doesn't matter. Just take your time. Now, after discharge from hospital, we will see you at the surgical assessment clinic 6 weeks after. These days, we don't bring you to the hospital. We actually video consultation, see you at home. Complications are not very common in this operation. So a lot of people they have very little complication after the operation. And if you have complication, you have to come back in. You come back in to sort. We will sort you out. Whatever the problem is. Now, follow up after donating the kidney is a lifetime follow up. We want to do. We want to learn, what has happened to people who have donated their kidneys in the past. So we will see you once a year. We say maybe on your birthday if you want to, so that you can remember. And we'll do blood checks. We'll check your urine, we check your blood pressure. We ask you some questions, how you are doing, and we'll see you the following year. Now, in summary, live donation contributes significantly to address the increasing demand for organs for transplantation. And we know it offers the best quality organ for transplantation with excellent recipient and allograft outcomes. However, changes in legislation have made it possible for adults to donate their kidneys to anybody you want to donate to. There are opportunities in the UK to increase the contribution of live donor organs to the organ pool, which is ongoing. This is one of the reasons why we are doing this talk. And especially the BME patients, to get the best quality organ for kidney transplantation. It's very important because live donor kidneys are better than deceased donor generally. So we want everybody to be able to get the best. Thank you. I'm ready for questions now.
Hey, thank you very much. Oh my goodness. So there are lots of questions right now, and I'm going to put them up as they're coming in. My goodness, that's a lot of questions. So I'll start from the
Okay.
beginning. There's quite a few coming in from WhatsApp as well. Um, so the first one is from NEA. So thanks for the invite, Hilaria. Very informative. Thank you, Dr. Tunde. I like the pace and materials. Okay. So and then another one is, what is the reason for incompatibility with a donor and a recipient from the same family?
Okay, that's a very good one. What the reason is, if, for example, you are a child is born from genes from two people, the two different people for that matter. And for example, if you have a family, you have the mother blood group is A, the father's blood group is B, and then the child has to be either AB, B, or A. So that means if for example the father, the recipient who is now the child is blood group B, the mother cannot donate to a blood group B if you are blood group A, for example. So that's incompatible. Now, the other reason is the HLA. We look at the HLA, the tissue type. Again, you inherit half of your tissue type from your mother and half from your dad. And so whatever you have at that point, sometimes you'll find out that the match is not very good with the either of the parents. It might be a 2-2-2, because if the mother is 2-2-2 with the father, then if you have a child who also may be 2-2-2 with either of them, then it's not a good match. And then the other point is about antibody compatibility, or what we call cross-match compatibility. One of the problems we find, if you have certain antigens that you've inherited from either parents, and then you find out that you have the antibodies to those antigens present in you at the time, and you will not be able to receive an organ from your mom or from your dad because you've got that antibody already. Okay, for example, when women they have a challenging situation, because when you are a woman, you have a child from a man, and some women will develop some antibodies against the man's antigens. So if they need a kidney, they already have antibodies. Although they are a family, but they are different. They are completely different individuals. And they may find difficult to be able to receive a kidney because they have this antibody which is already in their system. So they are not compatible. They may not be compatible with their husband anymore because they already have antibodies, or with any of the children because they already have antibodies against their antigens. So that's the reason why, generally, if you want to know, generally, the chance that, they're going to be compatible is higher if you are getting organs from a family than if you are getting from the general public. But in practice, this is not always true. You can be better matched with somebody who is not from your family than with somebody who is from your family. Okay. So that's why that's how it works.
Okay. So the next question is quite a long one, so it's going to cover the whole of the screen. In many BAME communities, the greatest hurdle I have seen is that people normally follow their religious leaders blindly. If the religious leaders could be persuaded, then that would make it easier to reach out to wider community within this group. Would you agree, or do you feel that there are alternative ways of handling this?
Yes, I do. I do agree. There has been a lot of effort that has been made to involve the religious leaders and to educate them and to try to let them buy into the idea of donation over time, because they don't know themselves. Sometimes they are also, talking from a position of lack of information, lack of knowledge. And they have also, because there's no religion that I know that is against donation or against any of their members receiving a kidney transplant. Even Jehovah's Witnesses, they accept kidney transplant. All religions accept kidney transplant. They will accept donation. But if the other point is, I think it's very important that we let people know that there are certain things, what we call patient autonomy. We need to also make people to be confident to make their own decisions about their own health, about their own life. It's very important we let people know that, their own life and their own choices is also quite important. But at the same time, we need to have constant communication with the religious leaders to try target them for education and discussion about what it all means, what life donation is about, what kidney transplant is about. I think that will help to improve the acceptance of donation and transplantation.
Okay, so the next one is from Sembowale Banjoko Hendricks. Can stem cell transplantation have a part to play in the healing of patients within end-stage kidney disease?
At the moment, that's not possible at the moment. Okay, it's a long story about stem cell, and I will tell you what people have done already. At the moment, it's not possible to use stem cells to produce a kidney. There have been some success in trying to create a kidney with stem cell, and it's not worked at the moment. So that's all I can say. So at the moment, it's something for the future, but for now, it's not possible for now. Maybe in some many years to come, we'll be able to do that. The kidney is different from other organs. It's quite complex.
Yeah.
So a lot of things has to get right before it can actually work. Okay. So we want a working kidney, not just something that looks like a kidney. At the moment, what we get is something that looks like a kidney but doesn't work.
Yeah, okay, thank you. This one is from Eniye Gez. I would like a brief clarification on pair or pool donor, that is exchange donor and recipient. How does that work? Can you be a recipient and also a donor? First time I'm hearing that. Dr. Campbell, over to you.
Well, okay. These are about two questions in one.
Yes.
How does the pair pool work? Now, if you have two incompatible donor-recipient pair, okay?
Yeah.
The donor wants to donate, the recipient wants to have a transplant, but they can't donate. They can't donate because they are incompatible by antibody or by blood group or HLA.
Yes.
If you go ahead and do the operation, it's not going to work. We know that. Our current knowledge tells us that it doesn't make sense to do it. It's just waste of time. So does that mean that that person cannot get a kidney transplant? No. These days, no. So what we do is that we collect all the pairs who are ready, who are able to donate all over the country. We now look at them and look at the pairs that can donate that are compatible with each other. For example, you can have a pair in Manchester. They are not compatible with each other, but you have another pair in Newcastle. The donor is compatible with the recipient in Manchester. And then the donor in Manchester is compatible with the recipient in Newcastle. So that means that the two can work. So that's how that works. So it's a lot of work that is being done to look at the tissue type. It's a lot of they go through all the antibodies, all the antigens, they pieces everything out and start seeing which one will work, which will not work. And now, so once they identify the pair, they will now do some further tests, antibody tests, or cross-match tests, and they mix the blood of the donor who is in Liverpool with the recipient who is in Manchester, and the donor who is in Manchester with the recipient who is in Liverpool. They will test their blood again. And if the test shows that they can't donate kidneys, then they will exchange kidneys. So the kidney, the donor in Manchester and the donor in Liverpool, in Newcastle, will go to theater at the same time.
Okay.
So that they don't change their mind, because nobody is allowed to change their mind at that point. They go to theater at the same time and they put to sleep at the same minute. So you give them opportunity to change their mind, but once you put somebody to sleep, then the other person has to go to sleep. Then the kidney comes out and the kidney will travel. Kidney travel to Manchester, kidney travel from Manchester to Newcastle, and then the transplant is done. So that's how it works. Now, can you be a recipient and also a donor? Yes, you can be a recipient and also a donor.
Oh.
It depends on what you are donating. It's very complicated. If for example you are a recipient of an organ, it depends on the organ you are receiving. You have received, and if you die, you are on the donor register. You want to donate some other organs in your body. Once we have all the information about your virology and everything and how well the organs are working, yes, you can be a donor when you die. But if you are a recipient of a kidney it's been done before, but I don't think it's a common thing that is done. If somebody dies, he has a very good working kidney, and then something happens, he dies, and they can still take that kidney and transplant it to somebody else. It's still possible, okay. But it's not very. It's not practiced widely. It's because logistics is very, very complex.
Okay. So she goes on. Eniye goes on to say, please, duration of the procedure. How long does it last? Basically,
the live donor operation takes about 3 hours. The laparoscopic live donor nephrectomy takes about 3 hours to do.
Okay. And
I should do only 10 minutes.
Okay, yeah. So I've got some questions, and someone sent a question in to say, what if the kidney is damaged while removing it? Can it be repaired?
Yes.
Okay.
Yes, the kidney can be damaged during the retrieval process, but I have never seen any kidney damage that we could not use it. We cannot transplant it. The surgeon is very, very, very careful when they are doing this operation. We have always, that I can remember, be able to repair any damage without any adverse consequences for the recipient.
Okay. Okay. And the next question is, what follow-up does the NHS offer overseas life donors?
If you donate your kidney you come from overseas, yeah. Is that the question?
Yes.
If you come from overseas and you donate your kidney to somebody in the UK,
yeah.
Of course, the NHS cannot follow you up where you are. Okay. But what we do is we ask you to go to your local hospital, and we tell them the tests that they need to do to follow you up.
Yeah.
and they can send the result to us and we can give advice.
Okay.
So the follow-up of every donor is our responsibility wherever you are.
Okay.
So yes, we can follow you up, but the test has got to be done by your local hospital where you live, and they can send the result to us and ask for advice if necessary.
Okay. So it says here, is NHS treatment available for overseas donors who have a disease detected on screening?
Overseas treatment? No. This is the way it works. Usually, you do all the tests before you come in. You do as much of the test as possible before you come in. We want to make sure that of the likelihood that the operation is going to go ahead. So it's not a waste of time for us and for you and for the recipient family and everybody. So we usually, carry out a lot of tests.
Okay.
Now, if in the event, that you find something in the donor that is not expected at that time. Now it's now going to be the NHS is the hospital who will now decide as to what's treatment they're going to give you. Whether you want to have the treatment here or you want to go back to your home country to have the treatment. Depends on what treatment you are going to require. So far, in my experience, we've not had that issue with anybody coming from abroad, to donate their organs. We've done a few in Manchester. People come from abroad to donate their organs and they leave, and we've not found anything for anybody. So we don't have experience of that in Manchester.
Okay. How soon before an overseas donor can fly back home?
Usually, within once the operation is done, they are well. It's usually about between 4 to 6 weeks after donating. They'll be able to be ready to get on the flight. Between 4 to 6 weeks, they need to make sure they have to wait for the immediate post-op follow-up appointment, the first one that we do after the operation. We've got to do that before they go home. Except if they want to go home, especially people who come from Europe wants to go back. They don't want to wait for 6 weeks. They said, we can have the test in my local hospital. They can communicate the result with you. I don't want to hang around here. Usually after 2 to 3 weeks, they want to get on the flight back because the flight is short flight, 2 hours, 1 hour, or something like that. So
okay. So this is a question from somebody. You said earlier on that somebody with certain diseases like HIV, cancer cannot donate. Can someone with HIV receive an organ?
Yes. If you have HIV and it's well controlled, well treated, and you are well, yes, you can receive a kidney. You can receive transplant, and you do well.
Okay. If a live donor subsequently needs a transplant, is there any priority given?
Yes, we do give priority. Yes, we have. I have been involved in only one in almost 20-something years who has come back, who donated a kidney when he was very young to his dad, and he's come back and he's now received a kidney.
Okay. Okay. If I donate a kidney to my girlfriend, will I be okay to look after her when she's discharged after the transplant?
You will be okay, but it depends on how much you need to do when you say looking after. If it means that you have to do all the cooking, all the cleaning, all the running around, that would be a bit too much for you. I would suggest that you find someone else to look after both of you when you are recovering, from the operation, rather than look after. Find a friend who can come and stay and maybe a week or 2 to look after both of you. That's the best option, I think.
Okay. 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 In the shared kidney scheme, does the donor have to travel to the same hospital as the transplant takes place?
The donor, what we do with the share scheme is that nobody travels. Patient does not travel. Kidney travels. That's
Okay.
the rule.
Okay.
People don't travel, kidney will travel.
Okay.
Except if you live in an area where you don't have a donor hospital close by.
Yeah.
Where you don't have a transplant center where they can remove your kidney.
Yeah.
Then you have to travel to the nearest transplant center where they can remove the kidney. But you generally, it's only the kidney that travels.
Okay.
Or should travel.
Okay. Great. Okay, I think there's just one last question. Quite a few, but I think you've actually answered all of them during your talk. I think it's just one more from Sembowale Banjoko Hendricks. So we tend to be superstitious. How do we combat that?
Superstitious about a lot of things, isn't it?
Yes.
I think it's mostly education, 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 education.
Yeah.
A lot of people don't want to have a transplant because they feel, oh, it's another person's organ inside me. I don't know what it's going to do. It will start controlling me. It will start getting into my brain. It will start making me behave like them. It will start doing all sorts of, stuff. Oh, all those things that happened to that person when they were alive is going to happen to me because they are now living inside me. Oh, people do have all these things, but this is not true. So one of the things that we have to do is just to reassure people that it is not true. Let them speak to other people who have had an organ transplant and to try to demystify all these beliefs that they have.
Yeah.
So I think it will take time. That's why we need to, engage all the people that can influence people
Yes.
positively in the discussion so that they can help people to come to a realization that, yes, this is strange for them. It's really a strange thing for you to have another person's organ inside you.
Yes.
So they can get used to the idea, and hopefully over time we can overcome this.
Exactly. So I think there are quite a few comments now, people thanking you. So Olive says this first session is really enlightening. I know I put this up before, but I'm going to put it up again. Eniye says, thanks for the invite, Hilara, very informative. Thank you, Dr. Tunde. I like the pace and materials of the lecture. Let's see, there's quite a few of them, so I have to scroll through. Okay, so Easy Finder says fascinating skills. I think they're talking about the operation. And then Anita says how interesting. I think, this has been really informative. And Olive, thank you, Mr. Campbell, for this enlightening and educating session. And Kantigi Talks says, watching informative, and I think that's true. Charles Kweku Odoi says it's very informative. And Eneye says, thanks, Mr. Campbell. This is now clear to me, repair and poll donors. Thank you. Charles goes on to say, strange myth. Thanks for clarifying, Dr. Tunde. And, from me as well, I want to say thank you. I was watching that video through the slits of my hands. I couldn't watch completely. It was just like, I was like, oh my goodness, is that what happened to me? As, a recipient receiving a transplant, a kidney. I couldn't believe that is what happened to me. but it was really, really amazing. So thank you very much, Dr. Campbell, for such an informative session. We really appreciate it. I know everyone has learned something today, as you can see from the comments, and they can now say they understand the life organ donation process. Hopefully, everybody watching, I hope that you did enjoy this. Thank you very much for attending again, and goodbye.